All right, well, I think we'll get started. Thank you all for joining our June pepper rounds. We're glad you could make it today. I'm excited to introduce Dr. Laura Baehr. She is an assistant professor in the Department of Physical Therapy and Rehabilitation Sciences at Drexel University, where she directs the PACEE Lab, Physical Activity, Access, Community, Equity, Empowerment. Laura is committed to maximizing the health and quality of life of adults living and aging with disabilities and chronic health conditions through community-based physical therapy. Her lab works to achieve this goal through multiple pillars, including the assessment of personal factors that sustain physical activity behavior, examination of intersectional social determinants influencing health and physical activity, development and evaluation of group exercise interventions, and the measurement of scale and capacity building to move evidence-based physical activity programs from the lab to the community. Laura's research leverages community-engaged practices, mixed methodology, digital health, and social networking principles. She has been invited to share her work in both academic and community settings, including annual meetings of the American Physical Therapy Association, the American College of Sports Medicine, the American Spinal Injury Association, the Gerontological Society of America, the National Dance Education Organization, as well as Columbia University, Alvernia University, and Adaptive Sports Northwest. So welcome, Dr. Baehr. We'll let you take it away.
Thank you, Dr. Bradley. So, everyone can see the slides? Perfect. Thank you so much for inviting me today. I'm especially grateful to join in at the Northwestern Pepper Center because of your specific focus on working with older adults with multiple chronic conditions, as well as the drive toward implementation science. And as Dr. Bradley said, my name is Laura Baehr, and I'm an assistant professor at Drexel University in PT and Rehab Science. Today, I'm going to share my training background and career goals, in part because it's always wonderful to get to know new people and potential collaborators, and also because I'm going to be coming out to the Pepper Center for an in-person visit next month, July 10th through the 12th, so maybe I'll get to meet some of you then. We'll review the importance of physical activity as a critical health behavior for older adults, highlight why older adults that are living with mobility impairments and chronic health conditions often experience more barriers to activity and some solutions to that. And then I'll discuss my ongoing research that's associated with this, as well as some planned projects. This is my training background and experience, which is really a combination of academic trainings as well as community-based work. I was always invested in the synergy between the mind and the body through movement, which is why I pursued my undergraduate dual degree in neuroscience and dance. And at the same time, I started working as a dance for Parkinson's disease instructor, which was a really great opportunity for me to blend my interests. Immediately following my undergraduate training, I became a research assistant in a movement disorders clinic. So we were working with folks who had neurodegenerative conditions such as Parkinson's disease or ALS or CBS or PSP. And oftentimes some of these individuals would have a cognitive impairment overlaid with the movement disorder. So that work plus my community-based work really drove me toward physical therapy training. And then because of my research background, I knew I wanted to be a clinician scientist, which is why I ended up pursuing my PhD. That picture you see of me with students is actually in a free community health clinic in North Philadelphia. So in my previous work prior to Drexel, I worked at Temple University, where I was a clinician educator in this free clinic, and we specifically worked with marginalized older adults living with mobility impairments. In addition to that, I'm an adapted exercise instructor. Most of the work that I do in that space is in online forums. So this image below on the right-hand side is myself and one of my colleagues filming for a national adapted sports organization called Move United. And then I also teach regionally for the Pennsylvania Center for Adapted Sports. So all of this training and background really informs my career goal, which is to move evidence, for the very strong evidence that we have for community-based exercise from the lab to adults that are living with mobility impairments and aging with those mobility impairments. My current research is focused primarily on spinal cord injury and those that are aging with their spinal cord injury. First, today I'm going to share with you how we used a community-engaged approach to build a group exercise intervention for this population. Then I'll talk about our current assessment of the effect of that intervention. And then finally, I'll share some of the limitations to that current work, which is informing my planned career development award. In addition, I'll briefly touch upon some short-term plan projects that I have to ground my work in aging research here at Drexel University, and they really inform one another. One is a hyperlocal project looking at the universal design assessment of the recreational center here at Drexel University, which is combined for Drexel affiliates, but also for use by residents in the community. And then also look a bit more at the Philadelphia region for capacity building for aging research. As a reminder to everyone here, as I'm sure we've thought about and heard about before, physical activity is a critical health behavior for everyone, and especially older adults. So both the CDC and the WHO specify national recommendations for weekly physical activity to support the health of older adults. Oftentimes, physical activity and exercise can be used interchangeably, but they're actually not synonymous. Exercise is a type of physical activity. And that matters because the definition of physical activity is any bodily movement that creates energy expenditure. So for an older adult, absolutely, that could look like going to the gym, working out on your own, or taking a fitness class. But it could also look like things like birding, gardening, walking, playing with your grandchildren. Ultimately, these weekly recommendations include 3 types of training. At minimum, older adults should achieve 150 minutes of moderate to vigorous aerobic activity every week. 2 times per week, engage in strength training activities, and then also incorporate balance activities. When we think about the importance of physical activity through the ICF model, or the International Classification of Functioning Disability and Health, which was coined by the WHO in 2001, we remember that functioning and disability have complex interactions, and also the health condition of an individual and the contextual factors that influence their life ultimately impact their ability to participate in their personal and societal roles. So for an older adult who achieves these physical activity guidelines, they're likely to be able to stave off the development of chronic health conditions, things that might affect the cardiovascular or pulmonary systems, or even multi-system disorders. But if they're already living with a health condition, it can prevent the exacerbation of that health condition or the development of secondary health conditions. In addition to that, it allows them to participate in the way that they want to in their daily life and also in society. And ultimately, we know that this is always going to be beneficial for this population for several reasons. Unfortunately, older adults are more likely to be inactive. So the work by Watson and colleagues that came out in 2014 in morbidity and mortality showed that roughly 28%, or 1 in 4 older adults, do not meet aerobic weekly recommendations. So they are not meeting the 150 minutes per week. And I specify aerobic because actually Wingwood and colleagues more recently worked on a survey of over 1,000 older adults and asked about aerobic, strength, and the balance recommendations. And unfortunately, only 11% of survey respondents were actually hitting all 3 of those domains of weekly physical activity. So generally, we know older adults are not as active as they should be to maintain their health, but also older adults who are already living with a chronic disease also do not meet those weekly recommendations. So actually 1 in 2, or 58% of older adults with a chronic condition don't meet those recommendations. We also know that with increased number of chronic health conditions, the risk of inactivity grows. And then older adults with a mobility impairment also do not necessarily meet those weekly aerobic recommendations, with 60% reporting that they are sedentary or falling below those national guidelines. So this is general information for older adults. Now we're going to talk specifically about a subset of population of older adults or adults that are living and aging with a chronic physical disability or chronic mobility impairment, and that's spinal cord injury. This is where the bulk of my current research lies. So over 250,000 Americans are living with a spinal cord injury. It's often due to a traumatic event, sometimes can be atraumatic, but ultimately results in partial to complete sensory and/or motor loss below the spinal level of injury. Folks with SCI, as you'll hear me refer to it for the rest of the presentation, have a high risk for physical and psychological secondary conditions. So what I mean by that is, If the SCI is their primary disabling condition, because of that, they are at increased risk for things like pressure injuries to their sacrum from sitting in their wheelchair and maybe not necessarily getting the weight shifts that they need, or anxiety and depression related to decreased participation. So much like generally for older adults, we know that physical activity is a key health behavior. It's especially true for individuals with SCI, and unfortunately, over half of them are sedentary. So this is important because there's this intersection of physical inactivity and aging. And the reason why is because the landscape of life with spinal cord injury in the United States has changed a lot over the past several decades. So in the 1970s, the average age of a new spinal cord injury was 29 years. Average acute care length of stay was 24 days, and inpatient rehab was a whopping 98 days. It's kind of unheard of now. And the most recent data we have from 2015, you can actually see that the average age of a new SCI has skyrocketed by 14 years. The average acute care length of stay is cut in half. And unfortunately, likely one of the most imperative learning times for these individuals right after their injury, their inpatient rehab length of stay has been cut by down to a third of the time that it used to be. One of the reasons, in addition to the growing aging population in our country, that SCI and that age has lifted is because falls are actually now the second leading cause of spinal cord injury, which we know older adults often are susceptible to. So keeping this in mind, not only is this population inactive, but the needs and perspectives of what it means to live and age with these injuries are poorly understood, which was the impetus for why we moved toward program development for this population. We used an evidence-based approach to build this intervention. The first step was to actually talk to the people who we were hoping to support, namely individuals living with chronic spinal cord injury. So when I say chronic, I'm talking about anyone who's been living with their SCI for 12 months or longer. We completed 2 qualitative descriptive studies talking with people living with chronic SCI about what they thought about physical activity, their needs and perspectives, and then also their perspectives about what it means to age well with their injury. In the first publication, Staying Active After Rehab, we completed small group interviews and found several barriers to lifestyle physical activity in this population. And what our participants were saying is that there's gaps in their physical activity education. So as I mentioned to you previously, rehab length of stay has dwindled significantly in the past several decades. Old folks who are living with SCI tended to used to get that physical activity information during their rehab, and it would have been for an extended period of time. Unfortunately, now that time is truncated, and also individuals are asked to go back into their communities and remain active, but don't necessarily have the tools to be able to do that. We also heard from participants that there's limitations in the knowledge of those in community-based settings. So for example, an exercise instructor at a recreational facility might not know how to teach to someone who's a wheelchair user, or unfortunately, many facilities are still not accessible. When it came to the second study, Perspectives on Health and Aging with a Spinal Cord Injury, we actually interviewed 24 people. They were living with their SCI from anywhere from 3 to 47 years, and their current ages were ranging from 22 to 76 years of age. Our participants shared with us that their health was directly linked to their physical routines to maintain their health and also prevent hospitalization. So our participants know the importance of movement. And they also talked about health being linked to engaging with other people living with spinal cord injury or other people with a similar lived experience with a disability. Unfortunately, aging outlook was associated with a fear of dependence and also the fear of the unknown. Our participants shared that they didn't necessarily have a lot of information on what life would look like to age with their spinal cord injury. So the link between these 2 studies, they actually did share some themes, was engaging with other folks living with spinal cord injury was really helpful, not only to learn about physical activity, but also to feel like you are healthy from a psychological perspective. And also that physical activity is important, but there isn't necessarily an understanding of how to maintain regular physical activity. So at the same time, as I mentioned to you previously, I was working in adapted exercise spaces. And of course, with the pandemic, everything went to a remote place. And so as I was adapting my teaching strategies to an online environment, I started to notice anecdotal success in these group-based exercise classes. That bottom picture you see with the blurred out faces is from a live group exercise class that I host through Pennsylvania Center for Adapted Sports. And it's a seated fitness class. So there were people who basically preferred or needed seated fitness, and that included people with spinal cord injury. So with that anecdotal success, I started to think about all of the elements of what I was doing in these community-based settings that were kind of answering some of the needs that we were hearing from our participants. And then when I looked to the evidence, what was available at this time, which at this point was a few years ago, we knew that telehealth was successful for secondary condition management, so remotely managing a pressure injury for people with SCI. We also knew that teleexercise was feasible, or online exercise was feasible, and online counseling for physical activity was feasible, but there was actually nothing for group-based exercise. So putting all of this information together, we ultimately decided to design a group-based exercise intervention that would be delivered online. The design of this program is responsive to the community feedback we receive. So not only do we complete those 2 qualitative studies, but we also have a community advisory board that we work with, and we did a lot of beta testing as we were developing the program. And what we were hearing, not only from those studies, but also from our advisory board, is that they wanted something that was going to be feasible. So an 8-week program matched what was in the available evidence, and it was also acceptable to our advisory board. The 2 times a week, 60-minute sessions is meant to push toward helping to sustain that national weekly guideline that we talked about previously. A really cool element of this program is that it's co-led by a person with a spinal cord injury. So because what we were hearing from participants is that they wanted information from experts, we ended up deciding that it was going to be co-led by either a PT or an OT or someone with rehab specialty, and then a community member with a spinal cord injury. The group format, again, was based on the feedback from participants as well as my clinical background. And then we incorporated goal setting into the program so each individual participant could really set their own thresholds for success as they progress through. We also used cueing, verbal cueing and visual cueing that was specific to spinal cord injury. So for example, if I were teaching this class, I wouldn't necessarily say, feel your hips in your seat, because there are participants with spinal cord injury who don't have sensation below their level of injury, right? So we tailored the language to really meet the needs of this population. And we also encouraged embodiment. A lot of the physical activity information and evidence that's out there for people with SCI is really focused on function. And while function is extremely important to make things meaningful and important to the individual, you want to make sure that you're giving them opportunities to really personalize the experience. So we weren't just talking about function, we were also incorporating elements to help people really ground and start to pay attention to their internal environment. So the program is called TEAMS, Tele-Exercise to Promote Empowered Movement in Spinal Cord Injury. And this is a video, and it does have audio, so I'm hoping it plays for you. We're working on cardio right now. So in this video, I really hope that someone can I have a thumbs up if you were able to hear that audio?
We were not, unfortunately.
Oh no, sorry. Well, then you were just listening to silence. Well, let me tell you, I was cueing them to engage in a cardio circuit. And so what I want to draw your attention to is that the 2 faces that are not covered are the co-leaders, which at this time, this is an older video, it was myself. We've since hired several folks to be interventionists, and one of our community advisory board leaders, Jim. And this is a combination of individuals living with different levels of spinal cord injury. So that includes cervical, thoracic, and lumbar. You may notice that folks were moving slightly differently or adapting things to their own bodies. So all of that work that I just shared with you really informed the development of this class. And while that was just a quick snippet, this is the fidelity checklist, and this is what a class looks like from start to finish. So it includes a welcome as well as a meditation. There's a warm-up and mobility section. There's a cardiovascular section. There is resistance training with both TheraBands and weights. They could be handheld or cuff weights, depending on the person's hand dexterity. And then a cool down and a checkout for everyone. An important note also is that this class is 60 minutes. The actual exercising component is 45 minutes, and then we leave 15 minutes for group discussion and a hangout, which encourages that social element. So our previous feasibility pilot, one of my favorite quotes that came out of our exit interviews is, "This taught me that I can instead of I can't," which is the ultimate goal and the heart of my work, which is to help folks really overcome those personal and societal barriers to movement so that they can sustain that physical activity behavior across their lifetime. We actually exceeded all of our feasibility thresholds that we had set for ourselves for success. We were able to target a pilot sample in about 2 weeks. We ended up with 11 people. 100% of the folks who started the program finished it, and we had a median attendance of 10 out of 16 total sessions. So remember that the program is offered for 8 weeks, 2 times per week. That's a total of 16 sessions. We did not mandate that folks had to participate for all of them in order to be in the study, because we wanted it to be a pragmatic experience, ultimately similar to what they might do as if they were going to a recreational facility and taking this class, or doing it online through an adaptive exercise organization. So we knew that this was a feasible program, and we were getting really great feedback from participants. So then we moved on to efficacy testing. And our efficacy study that is actually currently still ongoing is informed by social cognitive theory. So Bandura's social cognitive theory is actually very well used in exercise-based interventions, and specifically for those with SCI. And ultimately what it says is that those personal factors, things like confidence or self-efficacy to do a health behavior, as well as outcome expectations, or what you think is going to happen when you do those health behaviors, influences the actual practice of the thing. So in this case, we're talking about physical activity. If you're confident that you can regularly be active and you think good things are going to happen, you're probably more likely to do it. We also know that goal setting and working through social and structural barriers are really important to this behavior. So because of the way Teams is set up, we are addressing and responding to those design features that we know are important to our participants. And we also incorporated goal setting, and then we ended up measuring self-efficacy, outcome expectations, and behavior. I am a mixed methodologist, and so this is my mixed method study diagram. I'm happy to talk more about it if folks are interested, but one of the things, if you're not doing mixed methodology, just to know, is that there's different ways to integrate the 2 distinct data sets. And in this particular study, we equally weighted the data types. So the numeric information we were getting and the lived experience information from interviews were equally weighted and brought together to be integrated at the end of the study. We collected quantitative and qualitative measures at pre and post program, and then we followed up with the quantitative measures at an 8-week retention time point, or 16 weeks from the start of the program. These are the outcomes that we used. So you can see in the quantitative column, these were self-report outcome measures specific to SCI, so an exercise self-efficacy scale. And then we paired the focus group questions to really be able to elaborate on those numeric findings, like what influences your confidence to exercise the way that you want to. Same thing with outcome expectations. What do you expect to happen when you regularly exercise? And then the leisure time physical activity questionnaire for people with SCI. This one actually breaks down the questions into how many minutes in mild, moderate, and vigorous activity in that week. And we would ask our participants, what do you choose to do in your free time, and how do you choose to do those things? So these next few slides are reporting on our most recent publication that you can see in the bottom right-hand corner. I do have an update that I'm going to share with you with a larger sample. But for this particular publication, we ended up with a sample of 22 individuals. We were at 80% power when we ended up looking at this analysis. And you can see that we actually have a pretty even split between males and females. We had a large age range from 28 to 68 years of age, with a large injury duration from 2 to 50 years with an SCI. A combination of individuals with cervical and thoracic and lumbar level injuries, as well as injury completeness. Additionally, we actually saw an even better attendance median in this current trial, this efficacy trial, than we did in the feasibility pilot, which is something we were concerned about because the feasibility pilot ran in 2020. And so we didn't know, when this started running, because of things opening back up and us moving away from social distancing, we didn't know if that online method would actually hold up. And it seemed like people were still really invested in it. There are limitations to this, which I'll touch on a little bit more later, but please keep in mind in this table that you'll see that the majority of our participants are non-Hispanic white reporting for race and ethnicity. And then they're highly educated. So half of our sample reported having a graduate degree. And then a little over 25% of our sample also reported having an annual income over $75,000. This is integration of those two distinct data sets to give you a little bit more of information on how the findings inform one another. So in the top row, you can see that there was a positive significant change in exercise self-efficacy with a moderate effect size. And then below, this is just one example of a participant response from pre to post program. And just so you know, there's lots of quotes that we have that fit this theme, but this is just one that I wanted to share with you all. So at pre-program, this participant said, I really miss those years of playing rugby because it was a peer group and we would share resources, right? So talking about that social networking with other people with the same lived experience. At post-program, he said training for rugby in the past were dependent on other people helping us, and he's talking about the exercise equipment. A lot of the stuff we learned here is giving me a more independent option. So what's really cool about that is we heard some variation of this from several participants, kind of showing that that improvement in confidence to exercise the way that you want to was informed by the information they were taking ownership that they were learning in the program. From an outcomes expectations perspective, we also saw a significant change in the positive direction. So folks were feeling like if they regularly exercise, better things would happen. And a different participant at pre-program said, I want to do this. I really want to commit to it. And he's talking about the program. I think that once I get into it, it won't be as difficult, but I have a little, I don't want to say anxiety necessarily, but a little trepidation. At post-program, he says, he's talking about being in the class. I would see you all work really hard and it pushed me to work hard. Non-disabled people are doing this, so why not? Why not people with disabilities? You can kind of hear a shift in that person's anxiety about being part of something like this to really being able to see and having this low stakes practice opportunity to do the thing. And so what we really found was that people's positive increase in their outcome expectations was associated with the social element of the program, which is kind of linked to some of that preliminary work that I shared with you before. And then finally, what you'll see here is that unfortunately, we did not see a statistically significant increase in moderate to vigorous weekly physical activity minutes, even though you might notice that there was a 75-minute increase in the median. It was not significant. It was a large effect size, and ultimately, there was a ton of variability in the self-report of people's physical activity, which is a common limitation in self-report here. But one of the beauties of mixed methodology is that your data sets don't necessarily always agree. And sometimes that discongruence can actually lead to a more rich understanding of your findings. So participant 21 at pre-program said, I do a regular routine every day, 25 push-ups, 25 sit-ups. I need to do more than that. It's not enough physical activity. At post-program, they say, I try and just take what we're doing in class and try to add just like 5 to 10 minutes, like a couple of times throughout the day. I like the TheraBand because of the convenience. All of our participants had a TheraBand, and if you've used a TheraBand before, you can tuck it in a bag, take it with you anywhere. I remember another participant saying she takes it with her in her purse and uses it during her lunch break when she's sitting at her desk. So even though we didn't see statistically significant changes in the moderate to vigorous weekly physical activity, we did hear from our participants that there were elements of the program that led to portability, and then it allowed them to kind of find these, as I would say, movement moments throughout their day. Because of the large effect size, we were hopeful that if we moved toward a larger sample, we would potentially see significance, and that is what happened, which I'll share with you now. So this is not published. This is just our most recent analysis. This is with a sample of 37 individuals. Currently, we have 54 individuals total enrolled. It's just that we're running a session right now, so I haven't gotten through all that data. But with the 37-person sample, what you're looking at here is a display of pre-programmed themes that we heard from participants. There's personal trade-offs, like I know exercise is good for me, but I don't have the time. I don't know what to do. I'm afraid of getting injured. And then there's this social component to exercise. Am I going to need help? Do I know about the program? Is it expensive? How close is it to my house? All of these things that we heard from participants shifted at post-program. At post-program, we were hearing from a personal perspective that our participants felt like they had ownership of what they learned. There was social access and accountability in terms of the actual way that the intervention was being delivered, the group format, the online format, the expert leadership of the co-leaders. And that led to a sense of portability of what they learned into their everyday life. The same positive changes that we saw in exercise self-efficacy and outcome expectations remain. And now with this larger sample, we do see a significant increase in vigorous weekly physical activity. And most importantly, what's really exciting is that all 3 of these positive changes are retained at that 8-week time point. So we are moving towards sustainable physical activity and kind of not just dropping in, giving them something to do for 8 weeks and then not seeing that change over time. One extra little bit of information I want to share here is that we did use an exploratory aim to take a look at intra-class exertion. So we gave actigraph monitors to 6 participants within the class. We asked them to use the rate of perceived exertion scale to rate their own exertion for each segment of the class. And then we used what's called the monitor independent movement summary algorithm, which I can share later if anyone's interested, where we take the accelerometry data and we collapse it into physical activity counts. And then each person has an individualized threshold for what they consider moderate or above exertion. So for each of these 6 individuals, what we happily saw was that all of them were achieving about moderate or above intensity in the class for about 30 minutes, which is nice to see. So we know that participants are achieving that exertion within the TEAMS program. So all of these are great findings, but there's limitations. So I touched on this previously. You can see on the left-hand side, these are SCI national statistics compared to what we have here in TEAMS at this current time. We are disproportionately looking at a sample of non-Hispanic white individuals, also individuals who have high levels of education, high socioeconomic statuses, all of these social determinants that we know influence health outcomes. And ultimately, circling back to what we talked about before, those individuals that are marginalized with disabilities or mobility impairments are the ones that need these kinds of interventions the most to help sustain their health. But they're not necessarily in this sample. And this is a common issue with lots of intervention-based studies. So now going back to that evidence-based perspective, we've added all of this evidence for our program. And if you remember, I mentioned I work in these free and low-cost community health clinics working with marginalized older adults. And I'm just based on that experience and also understanding the literature, I started asking these questions, whose voices aren't heard? Who does this actually work for? What are the digital barriers that we may or may not have considered? Which leads us towards the next step for the project. So you might be thinking that we're getting closer to effectiveness, and that kind of follows that general, traditional pipeline for evidence. But as you all know, if you're invested or an implementation scientist, intervention research is maximized when you incorporate those implementation elements earlier on in the testing. So the ultimate goal of my Career Development Award, which is currently under review, is to actually tailor this intervention to the needs and perspectives of marginalized adults with spinal cord injury. So marginalization is going to be defined as 2 or more self-report of a low socioeconomic status, low educational, high school or lower, minoritized race or ethnicity, or a residential zip code in an area of high health disparity. And then from that sample, we're actually going to beta test and adapt teams, and then look at the feasibility and preliminary effectiveness of that adapted protocol. This work is going to be grounded by the Health Equity Implementation Framework, and this is just adapted to the project. But for those of you who are familiar with this or not, it is an adaptation of IPARIS, and ultimately it's showing that the factors relevant to implementation and disparities in healthcare have to do with the innovation and in the delivery of the encounter. So if TEAMS is the encounter, there is an interaction that's happening between the recipients, the intervention itself and the providers. And if we're not really looking at that from a health equity lens, then we're doing ourselves a disservice in terms of future implementation. So that's the thrust of this work. And if you're asking yourself, wow, that's a heavy lift, that's difficult to do, how are you going to do that? Because this is a common piece of feedback I've gotten. Philadelphia is home to some of the most socioeconomically disadvantaged Americans in the United States. And so there's a lot of people that we are not reaching locally, but also it has implications for the nation. So that yellow pin that you see is where my office is located at Drexel, which is right on the cusp of West Philadelphia. And you can see the red is representative of the most disadvantaged groups compared to the national average for socioeconomic status. And then those two blue pins are where I've practiced in those free and low-cost clinics that I mentioned to you. And again, you can see it's right on the border of those heavy areas of health disparity. So this is looking at the map of the area deprivation index that came out of Wisconsin, University of Wisconsin. So as I start to wrap up here, I'm just going to share a little bit about future projects. And I just want to share that the ClinStar Coordinating Center, or the Clinician Scientist Transdisciplinary Aging Research Network, is an awesome platform I've gotten a chance to be part of this past year as a health equity scholar. And it's really looking to influence the careers of early career investigators that are moving toward aging research. So while most of my work, as I've shared with you, is in SCI right now, it really is just a model for what it means to age with chronic physical disability and for those at high risk for the development or exacerbation of chronic health conditions. So globally, my work is focused on physical activity promotion, which is beneficial across all adults that are aging with these conditions, as we talked about, which has really informed my evolution towards aging research and why I'm so excited to share with you all and come out and visit. And Philadelphia, specifically at Drexel, we're the first age-friendly university. I have a great deal of support here through mentors and initiatives that drives Drexel's emphasis toward aging research and innovations. So my two short-term projects to really build a really solid groundwork for my aging research here at Drexel. There's a hyper-local project that I'm going to work on, and then a more expanded project at the Philadelphia region. So I'll start with the hyperlocal project. This is an image of the Drexel Recreation Center. It's really cool because it's unique in that you can be a member if you're a Drexel affiliate, but you can also be a member as just a Philadelphia resident. And currently there's 2,000 non-Drexel memberships at this recreational center. This center is state-of-the-art, it's ADA accessible, of course, but has never been assessed for the usability of older adults from like a universal design perspective. And so from my perspective, it's really an untapped health equity resource because we could be supporting the physical activity behavior of older adults that are already using this center and those that aren't for reasons we might not know. And so the thrust of this project is looking at the person, environment, occupation, performance model with one of my OT colleagues. This is a fundamental OT model. And so what we're going to do is look both at the person level as well as the environment level to improve the access of this recreational facility. So we'll deliver surveys to older adult members as well as non-members within a 1-mile radius of the recreational center. And then at the same time, in addition to using our clinical expertise, we'll deliver the AIM-3, which is actually a battery of instruments that evaluates the accessibility of recreational environments beyond ADA standards. So with the ultimate goal here to determine tangible strategies to adapt the recreational center to maximize participation by older adults, which increases usage, is a potential for research partnerships and participants that we can continue to work with. And then the second project is to build capacity for community engaged work here in Philadelphia. And for this, I'm using the EPIS framework, and I'm hoping over the course of the next year to really focus on the first 2 steps. For exploration, I'm just going to do a survey of all community-based organizations that are delivering free or low-cost services to older adults to determine their appropriateness and potential readiness to be part of research collaboration for physical activity. And then once I have that subset of identified organizations, we'll go into the preparation phase where I'll assess the feasibility of actually doing intervention-based work with these organizations, what they need, what they do have, what they don't have, to really get a better understanding of how to look at intervention deployment through these organizations. So in summary, thank you so much for listening to my work and allowing me to process alongside you as I continue to move toward my career goal. I'm really, really looking forward to meeting some of you in just a couple of weeks and to share more. I'd like to thank all of our collaborators, and I'd be happy to take any questions at this time.
Thank you so much, Dr. Baehr. That was a great presentation.
Thanks.
I'm trying to see if I can see everyone's screen, see if there's any questions. Feel free to raise your hand or just speak up, because it's hard to see everyone's little square at once here. I do see in the chat that someone definitely wants to connect with you. So,
oh, great.
You already gave your email and your contact information there. Does anyone have any questions for Dr. Baehr?
I can ask a question here. So Dr. Baehr, thanks. Jeff Linder here, and apologies for being on my iPad. You'll be happy to know I was moving around during your presentation. So I'm back here in my office. So sorry for the weird view. So our Pepper Center is very focused on primary care. So it's sort of it's a bit of a health system centric model, and I'd just be curious about your thoughts about, what do we, there's plenty we do badly in primary care, but if you could wave a magic wand, like, given the work you've done and the experiences you've had, what would you hope primary care, and we will definitely talk more about this when you come and visit, but just as a start, like, what would you want to see primary care do to help older adults with multiple chronic conditions move more, move better longer?
Yeah. Oh, I love that question, especially with the magic wand that, of course we'll never we'll get there right away. But if
I give you a magic wand.
Thank you.
Right now. Yeah, sure.
It's always good for us to be able to dream, right? So, I had a little bit of experience because one of the clinics I was sharing with you all was sort of a primary care model for social work, physical therapy, nursing, medicine, and pharmacy. And first, I would say, if you're going to really promote that person-centered care and promote health, whether it be at visits or when that person is living their life in their community, it would be really great to have all of those people on the team, which I'm sure you're working toward or you're already doing. Another really something that kind of grinds my gears is that one question about movement that a lot of times folks get in primary care is, have you fallen? And then oftentimes there's not necessarily follow-up, like, well, of course there usually is, did you hit your head, which of course is very important, but how many times, how did it happen? Have you gone to rehab? Is there a referral to rehab? And relating to that, it would be really awesome if I had a wand to have folks do a movement screen annually, just like they get their blood drawn, just like they go for their annual visit. They actually have a primary care PT style movement screen to catch preemptively some of those risk factors that might be influencing that person falling, for example. And that's just one, but yeah, those would be my first two waves.
Love it. Yeah, we definitely have a lot to talk about. I have lots of thoughts too, but let me let other people jump in here. So thanks so much.
Yeah, thank you.
Bill Hilly, you have a question.
Yeah, thanks. Hi, Dr. Baehr. I really enjoyed your talk. I'm here with my colleague, Marjorie Hilliard we're from the Department of Physical Therapy here at Northwestern. So we were especially interested in meeting you. I had two questions. One was, is the PT necessary as a co-leader? And I'm wondering, what are your thoughts in sort of a train the trainer to move this? I mean, is PT going to always be involved, or is this something that the community can be the leaders? That's the one question. And the second question is, I'm thinking your participants were urban, they live in Philly. And what are your thoughts of moving this? How would this work in rural settings where I see the need too?
Yeah, great questions. And PT represent, great to meet you both. So absolutely moving away from having PT as one of the co-leaders as one of our goals. And I'm really glad you brought that up, because it's almost like as we continue to adapt the program, we move away from some of the things that we thought were the answer in the beginning. So when we were hearing from participants that they wanted expert leadership, yeah, it's great that it could be a rehab specialist like a PT or an OT, but that also means that in order for us to push this out and get it to community-based organizations, you can't always have that therapist, right? And actually, frankly, I don't think it needs to be a therapist. I think that was really helpful in the development and feasibility stages, but now that we're seeing success and we have a thorough training protocol, absolutely. So that's definitely for our planned hybrid study in the future. And then remind me of your second question.
I was asking of your plans for moving this to rural
Yes.
communities, because it seems like your population was urban.
Yeah, and I don't think I have it in my slide deck here, but even though I'm physically in Philadelphia, because this is online, we actually allowed participants to join from anywhere in the United States. So I used to have a map where I could have shown you where they're all residents were located, but we don't have folks just from an urban environment. We do have, I can think of a woman right now. She's out in Tennessee. She's like 4 hours from an SCI model system. And she was able to finally get connected with other peers. And on the back end, after they were finished the study, they asked to be connected, and we started connecting them on the back end. So we have already started to see that, but I will agree with you, rurality is another social determinant, right? Geographic location influences health outcomes. So that's definitely something that I'm keeping in mind as I keep going forward.
Great, thank you.
Thank you.
And I hope to meet you when you come to Chicago.
Oh, me too.
Great. Thank you. Other questions?
I've got a question.
Oh, hi, Alan.
Hi there. Thank you for your presentation. I very much enjoyed it. Spinal cord injury is an interesting condition. You mentioned that many people sustain injuries because of falls as older adults, but it's a stable condition for the most part, and other than other aging-related conditions that might co-occur, tends to be pretty stable. I'm wondering how translatable you imagine your intervention might be to the other populations that you mentioned, ALS, Parkinson's, MS, for example.
Yeah, great question. So I will say that there's a couple of pieces in the literature that show that 1 in 3 people with spinal cord injury within that first year will go back into the hospital. But to your point, once they're kind of in that chronic phase, they are a little bit less susceptible to being hospitalized. But what I will say is anyone in our current efficacy study who had to drop out or take time off, it was because of an exacerbation of a secondary health condition, or they were hospitalized. And that's actually unfortunately, one of our exclusion criteria is if you've had one night overnight in a hospital in the past month, you cannot participate. And we lost some people due to that. So we have seen a little bit of medical instability in our sample. But to your point about translating it to other folks, like, for example, people living with ALS, it's really a different, I think what you're getting at is like that rapid time course, right? It's just a completely different time course. And so their needs and perspectives are different. And what I would say is I do think this kind of intervention is adaptable to different populations, because it all started with a community-based program that was for a mixed population. They all just wanted or needed to be seated. It's just a matter of hearing from the needs and perspectives of those people and then integrating that clinical experience. So I would probably just start this process over again from the ground, from a pilot, and including community advisory board members that have that lived experience, because I think that really catapulted our success and the speed at which that we saw effects, for sure.
Thank you.
Thank you.
All right. Well, thanks again, for Dr. Baehr, for a great presentation. We're looking forward to your visit later this summer and seeing you in person. Thanks, everyone, for joining our Pepper Rounds this month, and we'll see you again soon.
Thank you all. See you soon.
Have a great rest of the day. Thanks again.